Welcome to GutTalk by Deb, Dr. An and Dr. Bigan, a YouTube channel focused on closing the communication and knowledge gaps in gut health. Please press subscribe button below. Hello everyone, I'm Dr. Yoon An.
And I'm Dr. Jakob Bigan.
We are gastroenterologists from Australia with subspecialty focus on inflammatory bowel disease.
We face an unprecedented situation with a global pandemic of COVID-19. Understandably, there is a great deal of anxiety among our IBD patients and their practitioners. There are many questions about how best to manage IBD in this challenging setting.
It is our priority to minimize the risk of IBD patients from COVID-19 while also managing their underlying IBD to prevent flares and complications. We put together this video based on GESA recommendations to address the concerns of healthcare providers looking after IBD patients.
Patients on immunosuppression may be at higher risk of developing severe disease if they contract COVID-19 infection, although that evidence is still emerging and the magnitude of the risk remains unclear. The highest risk group of severe COVID-19 infection appears to be the elderly and those with underlying medical comorbidities, including cardiovascular and chronic lung disease, as well as diabetes. These groups tend to develop more severe disease and have higher mortality. Therefore, steps that vulnerable patients can take to minimize their risk of infection with COVID-19 should be encouraged. Those measures and recommendations have been developed by state and federal government and health departments.
Practicing good hygiene and social distancing are the most effective means of risk reduction. You should encourage patients to follow the advice from the state and federal government. You can refer them to the official link below.
Influenza vaccination is recommended for all patients with IBD and should be encouraged when it becomes available this year. Pneumococcal vaccination is also recommended for patients requiring immunosuppression unless contraindicated. Details of pneumococcal vaccination indications can be found in the GESA-IBD clinical update. Please see the link below.
Please minimize direct contact between physicians, nurses, and patient where possible. Therefore, remote patient management via telehealth and telephone are encouraged. You can utilize the new telehealth and telephone MBS bulk billed item number. Please see the link below.
If infusions can be performed outside of the hospital or in a location in the hospital that minimizes risk of exposure to patients, then this should be implemented. For appropriate patients in long-term stable remission, infusion interval lengthening may be considered. There are inadequate data available to recommend switching from intravenous biologic therapy to subcutaneous therapies.
Non-urgent endoscopy for IBD patients, such as surveillance or routine post-surgical assessment, should be delayed. Non-invasive biomarkers and imaging should be utilized for disease activity assessment wherever possible. Endoscopy in symptomatic patients where the result will affect management should be considered depending on your hospital's policies. However, when performed, appropriate PPE should be used as per your local guidelines.
Patients do not routinely need to be taken off immunosuppression or biologics. They should be continued on the minimum level of immunosuppressive or biologic therapy to control disease activity and minimize the risk of a flare. Some patients with long-term stable disease may be able to be considered for a drug holiday.
For patient flaring, it is important to treat their underlying disease regardless of their COVID-19 status, and this includes initiation of steroids or anti-TNF therapy in setting of severe disease. Exclusive enteral nutrition may be an attractive alternative for patients with Crohn disease.
For patients with symptoms concerning for COVID-19 or exposure to someone with known COVID-19, they should be self-isolating and tested per local guidelines. Management of immunosuppressive medications will be on a case-by-case basis.
For patients who contract COVID-19, consider holding therapies that may impact ability of T-cell mediated viral clearance, such as thiopurines, anti-TNF agents, ustekinumab, vedolizumab, and tofacitinib. Typical symptom duration is 3 to 5 weeks, and a pause in therapy of this duration is unlikely to precipitate a major flare.
If you do have any patients with IBD that develop COVID-19, please consider enrolling them in the International Registry. Please see the link below. Thus far, the majority of IBD patients with COVID-19 that have been reported have not required hospital admission or ICU care.
I hope you find this guidance useful. If you have any questions or concerns, please leave a comment below and we'll try to address it.
Most importantly, please stay safe. For more GutTalk TV updates, please press the subscribe button below and stay informed.